We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, Doctor of Physical Therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together. Welcome to the Healthcare Revolution podcast. I'm so excited today to have one of my greatest mentors on social media. I followed him for years, and he has really just shaped a lot of the way I think, all about resilience and really truly believing that our bodies can adapt to the demands that life brings upon us. And today we're talking about your joints and how they're not wearing out. The truth about joint health and movement. Many of us are told throughout society when we get x-rays or MRIs that our joints are degenerative, they have arthritis, and today we are going to demystify a lot of those statements. There's reasons why we have those statements in imaging, but it's specifically for healthcare and our understanding, but those terms can be very damaging and very not helpful. So I have Dr. Samuel Spinelli with me, and I'm going to introduce him, but I want to give some background to the topic that we're addressing today, because millions of people are told that their joints are wearing out. Patients are often shown imaging, again, that shows degeneration, arthritis, bone on bone, and they're told that their bodies are simply breaking down with age. But is that actually true? Or is it one of the most damaging myths in modern healthcare? That's really what we want to dive into today. So we're challenging the outdated narrative of this wear and tear, and we're exploring the reality of what's really happening. So what if pain doesn't mean damage? I really want you to think about that. And if movement is actually the solution rather than the problem. I want to challenge that status quo today. So our guest today, again, is Dr. Samuel Spinelli, Doctor of Physical Therapy and Strength and Conditioning Specialist. He really focuses on evidence-based rehab and bridging the gap between rehab and high-level fitness and performance. He started his early career wanting to work with professional athletes and decided that wasn't really where he wanted to go, and has made some shifts in his life. And now he really focuses on bridging that gap between rehab and performance with a lot of online people. So if you want to work with an online coach who is a doctor of physical therapy, he's a great resource. But he really focuses on education, coaching, and clinical practice. He challenges outdated beliefs around injury, pain, and joint health. And his mission is to help people realize their bodies are truly adaptable. They're resilient and capable of far more than what they think they are. So, Dr. Spinelli, so good to have you on the podcast.
Thank you for having me. It's wonderful to be here. Excited for this talk.
Yeah, I appreciate you being here. Tell me what really inspired you to live this mission and carry it out of talking to people about their health, joint health, and how these markers can really be disruptive in their health.
I think one of the earliest things is I grew up in a culture of where health wasn't really a big priority. Not to say that it was disregarded, but it definitely wasn't a forethought. I come from a rural part of Canada where, people are working hard, spending a lot of their time and effort on that, and they come home and they just check out. And I see a consistent phenomenon there where a lot of individuals struggle with a similar pattern of poor health that then lines up with these challenging side effects that we see. Individuals struggling with diabetes, these negative side effects coming with various types of cancer, and a whole host of poor health effects. And as I went through my education, I started to learn a lot more about how these can often arise out of secondary effects coming from lifestyle factors, and that they can heavily be mitigated through, making certain choices and encouraging certain movement options, patterns and choices, and additional options such as, the way that we approach sleep, nutrition, etc. And I just found it so fascinating and something that, coming from where my background was, never discussed, not highlighted, and rarely ever considered. And as I started to open up that discussion with a lot of patients and clients, whether it was for rehab or performance, I saw that there was often this major gap where no one had ever really discussed it with them. And a lot of times they were very open to the discussion. And we saw this really significant benefit for a lot of people with just making some subtle choices that then compounded over time. And now, as I've been a clinician and coach for a lot of years, I've seen individuals who I've worked with and seen that improvement maintain, and then also compounding effect where it was someone who, for instance, really struggled in basic movements and they were starting to get up into older age, and we were able to create a change and then see that compound where at first they struggled in just getting out of a chair, whereas now they're able to do stairs and go hiking and explore the world around them without any limitation. And I just always thought it was this area that unfortunately was really not highlighted and not discussed to a full degree, and could benefit so many people from exploring and considering.
Yeah, I love that. The biggest challenge I feel like people actually have is that they start to hurt and then they start to move and they're like, oh, I need to move, right? And then the movement hurts and then they feel stuck, right? And what I love about what you're saying is the movement is the medicine, but sometimes adapting the movement to where you can do it is really the most critical part. Sometimes you need some variability to bring it back to the level where you don't have pain, right? But people don't understand how to build that bridge because maybe the level of difficulty from standing from a chair is way too much for you right now. And there's 20 ways we can modify that to where you can still move and move out of pain, but there's a huge barrier there. At what point in your career did you notice this issue where you're like, man, I got to get people to understand at a different level? What was kind of a light bulb moment for you in your career?
That was actually before I even got into physical therapy. I was a strength and conditioning coach, and I had a lot of individuals that would experience an injury, and then they'd go through essentially a similar process you just outlined, where, I'm working with a high level hockey player. They end up experiencing a groin tear while they're playing hockey. And then the mindset was, I'll just do nothing. And then eventually, when they were somewhat pain free, they would come back. And the rehab process that they went through during that timeline was maybe not the best. And when they'd get back into the training floor or the rink, they would really struggle with activities. And you could notice immediately that they would start to move in less than desirable ways because they were in so much agony still returning back to that activity. And it didn't seem like whenever I'd speak to people that there was someone who was really guiding how to make that bridge between, I have this issue with this activity, and every time I try to do it, I have pain and I struggle in performing it. So I just do it in a different way. And no one was guiding them, okay, well, how can we go from that issue back to it? And then as I started to work with patients, I saw the same kind of idea come up. And I wanted to try to find some option to see if I could smooth things out and help to create a clean transition for individuals. And fortunately, I had some mentors that, were of that similar mindset and started to put me on a good path. But yeah, I think unfortunately it was something where it's seeming like physical therapy is adopting a much better mindset about it now. But for the longest time, I think there was just this idea that if you have pain, don't do it, stay away from it, don't go anywhere near it. And then there was no discussion of, okay, you have an issue with something. How do we get you back there? It was just, well, you just don't do that for the rest of your life.
Yeah, I love that. Let's dive into a specific example because I really want our listeners to truly understand what you're saying here. So say for instance, you have someone that's walking up and down the stairs. And walking up the stairs is fine, but walking down the stairs is super painful. What is a modification typically they would, or not a modification, what's a compensation that what someone would typically do if they're painful walking down the stairs? How would they change their movement?
Yeah, so typically when someone has that problem, we're normally going to see it on the front part of the knee. That's where they're usually going to have that main complaint. And so to take load off that region, they normally take what we call like a hip hike strategy or a more hip dominant position. And from that, they start to load their hip in a different way than they're used to, which is not inherently a bad thing. But as any sort of injury can arise, when we take a different position, different pattern of movement, if we go from zero to a significant amount with that, we can predispose ourselves to a secondary injury. And so, as an example of that one, where you're walking downstairs, you have pain with going down, so then you start to adopt this more hip dominant style. You might notice that your hip gets really sore, the deep part of your hip gets discomfort with it. You start to shift and really rotate your pelvis to be able to get down the stairs. And so then you start to get this secondary issue of where you have this second line of hip issues that come even though you originally were having a knee issue.
Yeah, so essentially they start loading the hip significantly more, causing this rotational compensation through their spine or through their pelvis, and then they can develop this hip pain. They also can develop that back pain, right? There's all these compensations that can happen over time, and all because it hurts to go down the stairs. But what's things that we do in physical therapy? Maybe give some generals on what we can do to modify to allow people to potentially go down the stairs, or maybe adjust going down the stairs with volume. What are some parameters people could think about to really understand this concept you're talking about?
Yeah, I think there's a few ways it is always best to approach it. So the first one I like is what I call activity modification. And so in the case of the stairs, we're descending the stairs, we're trying to minimize that stress on the knee. Instead of going and having just one option for descending the stairs, I want to take that person and see, okay, can we find a few different ways that we can do this? That way we spread out the load that we're going to experience. Because if I just go forward and only use one strategy for all of it, it's going to be a very significant new stress. And so then instead, can we find a way to go down the stairs, maybe where we have that more hip dominant style from a forward back direction, but could we also have a slightly rotated position where maybe we go down the stairs at a slight angle? Can we also go down the stairs utilizing a support like the rail on the side if we have that option? Can we look at a few different ways that we can utilize that? In some cases that are more extreme, do we need to incorporate an assistive device? Can we consider utilizing our ankle to a higher degree? And just look at it. Are there a few different ways that we can modify it to give us options? And that way, if for instance, you find that you're starting to do quite a lot of stairs and we don't want to end up irritating your hip, so then we can have a few different ways. That way we spread out that stress across the regions. And then maybe we can find a way to descend down the stairs, still using your knee, but in a way that's not as overloading. Like, for instance, if we do have that slight rotated position, where maybe instead of, if it's your right knee that's bothering you, you turn to your right slightly, and then you might be able to adopt the same kind of general movement, but because your knee doesn't go as far forward, you can basically go down the stairs the same way. And that would give you an option to still use a similar pattern, but just not as significant of loading through that motion. And then, in addition, doing some supportive exercises that start to try to target the area. Because typically, what we're going to see is that the area got bothered for a few different reasons. One is that maybe you were doing way more stairs than usual and it just got overloaded. But that's usually not the main thing in most populations. Like, most people don't go, hey, I suddenly decided to descend stairs 20 more times than usual. Like, it's usually that someone started to have this issue arise because they had a decrease in their overall physical abilities. And that was the thing that emerged as the problem. And so it could have been that, over time you were less active. And then this is the thing that compounded and is, so to speak, the straw that broke the camel's back. And it's the thing that first broke down and highlighted the problem. And so now we want to look at, okay, if that's the case, can we look at improving your general physical abilities? So this might mean that we do really non-specific activities. Can we look at getting more walking in? Can we look at doing some cycling, some air bike, some general physical motion that might help to improve your overall health? Yeah. And then doing some highly specific movements that really target that region of the body and help to encourage it to improve its capacity. So in this case, if it's the anterior knee, the front part of the knee, that means that we're probably going to be trying to challenge muscles like the quads, along with the patellar tendon and that patellar region. And so that might mean doing some wall sits, some leg extensions, or some variations of squats where we can structure them in a way that doesn't increase your discomfort, but allows us to really train it and improve the abilities with it.
And I hope you're
And
really
so,
catching what Sam's saying here. There is non-specific exercises that give you variety to your knee, but then there's specific exercises that we're doing to target the exact tissue that is causing the pain, that we are changing the capacity of that tissue to adapt. Because essentially, Sam, correct me if I'm wrong, but you're saying most people that have knee pain with that type of activity did not enough activity for too long, and then essentially jumped back into the activity and did too much. So you're doing too much after doing too little. Is that correct?
yeah, absolutely. Yeah, essentially. And that's unfortunately what we see for a lot of individuals, particularly those in like middle to later ages, where You probably didn't really notice that you were losing your fitness, not really noticing a decrease in muscle mass or strength, anything like that. Because, when you look at this in research, it's a relatively slow decline until you get to significantly older ages like 70 plus. For a lot of people, it's like a 1% to 2% change per year, which most people aren't going to really notice. But when you have that 1% to 2% change over 10 to 15 years, that's a pretty significant amount. Like if I said, hey, you're 15% weaker than you were 10 years ago, you would probably be like, wow, that's a problem. And to be fair, it is a problem. And people don't notice that though. And that's one of the bigger challenges
And
because
the
they
reason they don't
often
notice
have
is,
that issue arise and they're like, oh, my knee hurts.
yeah,
What happened?
and the reason they don't notice is because it's compounding over years, right? If you're losing 2% strength over a 15-year period, you could see how that is so gradual you don't really see. I mean, it's like looking at a plant. Do you see a plant grow as you're staring at it? No. But if you take pictures over weeks, obviously you're going to see that growth. But it's really hard to see a decline in muscle mass or muscle strength, over a 10-year period. But yes, I love that you're saying 15% decrease from where you were X amount of years ago. That becomes a problem. And with basic biomechanics, the knee joint reaction forces significantly go up when the strength of the muscle goes down, because your muscle is unloading the joint, but if you don't have the control of the muscle, the joint has to take more of the load, and that's where it can be painful because it's not used to it.
Yeah, absolutely. Like at the end of the day, I think a relatively beneficial concept to think about is that any activity that we do has a set requirement for demands. If I stand up from a chair, I have to produce a certain amount of force and take a certain amount of force in. How and what receives that force is going to be determined by a lot of factors, one of which is how strong my muscles are. If I'm really weak, then like you said, unfortunately, it's going to be passed a lot more onto my joints and I'm going to notice that discomfort more. In contrast, if I'm really quite strong and I have a lot of muscular abilities, I might not notice that discomfort because it's not going to be distributed to my knees. And so we can really manipulate and choose what ends up experiencing a lot of these forces based upon what our abilities are.
Yeah, absolutely. Tell us, if a patient has been told, say they're walking down the stairs and they have this pain, and they've been told in the past that they had bone on bone or this wear and tear in their knee. Tell us what that wear and tear means and why that's an issue.
Yeah, that's a really troubling one because there's some truth to it, but it's not true in and of itself. That's one of the biggest challenges that comes with it because when we look at, for instance, imaging, we can see that there is a general trend where bones do get closer together. We do see more bone growth with age. Those two things are true, absolutely. But unfortunately, we don't see a consistent trend that change in and of itself equals pain. And that's a really challenging one for people to understand and appreciate, particularly when they go see their physician and he says, you have pain because of this image or this change in your knee. And we actually have research that's been found that when someone's been told that, they strongly associate with it. And it's very difficult for them to change that mindset. And that's one of the most challenging things to work with individuals on because once you've associated and aligned with that diagnosis, it can be difficult to combat that. What we do see is that even though that imaging might be present, individuals can have an incredible amount of function disregarding that. For instance, we actually see in a lot of really active populations the exact same imaging as inactive populations. But one of the main determinants that's separate of that is their otherwise health. And so people often get really locked in on what does my image say? And it's not necessarily a really good reflection of their actual ability or a determinant of what their pain should be. And, do we see wearing and tearing occur with joints? Absolutely. There is some truth to that for sure. And that's where it becomes difficult in separating that for a lot of patients because it would be wrong to say no, wear and tear doesn't happen, but the degree to which we focus on it is probably highly misplaced because we see that wear and tear starts happening as young as teenage years and that it just starts to compound to a degree over time. With that said, we do have evidence that we can also minimize that with some of our choices. And so typically individuals who have better overall health tend to experience less of that change and also experience less discomfort with that change. And so, even if it is happening, we can still change the degree to which we deal with the discomfort that might come from it.
Absolutely. And I want to add a few thoughts to what you're saying, because I think this highlights that wear and tear, you can speed your uh, the health of your joints up by certain choices, like you said, right? Whether that be nutrition, whether that be sleep, right? Whether that be physical abuse, right? Say you've taken some significant traumas to your joints, right? You fracture your knee, like in motocross, I broke a lot of bones, right? And if my joints take up, I fractured my knee and, it's fractured in 10 different places, that's going to play a role, right? And then say I've ignored pain for years. We would call that potentially wear and tear, right? Because you are literally, maybe you've lacked quad control. Your thigh muscle isn't very strong, and you're demanding going down the stairs thousands of times for your job, and you've ignored this check engine light of, oh, my knee hurts, right? The joint has to take up that load that your muscle isn't taking up, and it's taking it over and over and over, and eventually the meniscus and the articular cartilage wears down because the joint wasn't intended to take that load up, because your quad muscle was supposed to take that load. So yeah, I completely agree with what you're saying. Like, there is truth to the wear and tear, but I think the gap there is that most people think wear and tear just happens, in my late teenage years, and I'm doomed to destruction and I have a bad knee the rest of my life. But tell us what happens when you start to exercise a knee. What happens to articular cartilage, meniscus, in weightlifters, in people that actually load their knee appropriately? Tell us what happens there.
I'd love to talk about that, but I want to double up on actually something that you said, which I think is really great, in that within that whole idea of wear and tear, a part of it comes that where people do say, oh, I did a lot of this activity and that wore down my knee. And I think one of the greatest examples that we have that kind of contrasts and challenges that idea is with running populations, because fascinatingly, we see that when they look at how much volume a runner does, there's actually an inverse relationship. So, inverse relationship means that as one thing goes up, the other thing goes down. And what they've found is that there's an inverse relationship with knee pain with running volume. And so, as someone actually runs more, they experience less overall knee pain. Now, that doesn't mean that if you have a lot of knee pain, go run as much as you possibly can and it'll magically be better. But what that challenges is this idea of where if I run a lot or do a lot of an activity, it will wear down my joint. And that's where we've seen the research come out and push back on that idea, because a lot of people who actually do a substantial amount of overall activity don't necessarily see those joints wear down. For instance, there's a really interesting study looking at rowing populations and a similar concept to their back, where they accumulated a really high volume of rowing, moving through flexion and extension, having their lower back move significantly. And they did notice that over the course of a season where they do a lot, they did have a decrease in some qualities that maybe isn't desirable. But the moment they took a break, they actually had a huge rebound and their overall qualities were way better. And from doing that activity, their back was much healthier than the average person's back. And so it's this really interesting challenge of where we often perceive that doing a lot of activity wears down the joint, but instead, so far, most of our research shows the opposite, if anything.
Absolutely. You even think about the research in strength or in power lifters. Power lifters have the thickest discs in their spine, right? They have the thickest articular cartilage and meniscus in their knees, right? Because their bodies are adapting to the demand that they put on them. But it has to be progressive. And I love that you clarify, just because we talk about these things doesn't mean go be a power lifter tomorrow, right? There is this nice trend that you have to go up. It has to be linear. You have to do it over time. The competitive runners have the most amount of knee arthritis, right? Knee issues, but recreational runners have the least amount, right? And sedentary people have almost more than the competitive runners,
Competitive,
right?
yeah.
So how can we meet in this middle ground? Because I love what you're saying, like with these rowers, with that research article, is like too much can be good, but you got to let your body recover. You got to let it build up, right? If we're constantly beating it down, it can't build itself back up. I love that. Any other thoughts on wear and tear? And in the message that we really got to get the community to understand.
The idea extends out so far across the body and these different areas where people end up perceiving a lot of exercise to have negative effects. And it's just this interesting concept that's oddly enough only been disproven when it's been checked. Even looking at, for instance, like individuals with osteoporosis, we've got this fantastic group of researchers in Australia that have been running a collection of different studies. They call it the Lift More trials, where they take
Love
osteoporotic
Morse,
women
yeah.
predominantly, and then also now osteoporotic males. But with these osteoporotic women, they have them come and they do powerlifting essentially. They squat, they deadlift, they overhead press, I believe, and they do a variation of a jumping pull up. And then they scale that over time based upon how much weight they can handle. So they're not going and using these crazy amounts of weights, but it's just like, okay, you're going to perform 5 repetitions at a weight that you can safely do. And then over the next 8 months, because it's usually how long the studies are, we're just going to see if we can have you do a little bit more over time. And then fascinatingly, they have almost no injuries and they all improve in bone mineral density, one of the primary things that we're trying to change. In a lot of those populations, even with like medications and bone stimulating therapies, they have inferior improvements than they do with just quality resistance training done consistently over time with progressive overload.
Yeah, and I love that Lift More study. If you haven't looked up that study, please do, because osteoporosis, weak bones, develops over time, specifically more in women than men. It does happen in men as well. But bones, based on Wolff's Law, a law is irrefutable, right? Wolff's Law states that bones will adapt to the appropriate demand that you place upon them. And really, if you think about it, Wolff's Law is specific to bones, but that same principle can be taken to every tissue in the body. But the definition is very specific. It's the appropriate demands over collapse time. And the Liftmore study does a really good job at the appropriate progression over time and having skilled professionals jump in and say, this is appropriate, right? Because someone might go lift up a barbell and they're like, I can't do a deadlift. And it's like, well, there's 1,000 ways we can do that deadlift. And let's modify that deadlift so you can do it, and then we'll build it up over time, right? And it's really hard for people to understand and just YouTube a bunch of exercises on modifications because they don't have the training in it. And it's easy for us as, doctoral level educated individuals to say, oh yeah, let's bring it down 4 levels, right? But in their mind, it's either a deadlift or not. But we could have 17 modifications for that deadlift, and we know, okay, let's try that. That's too much. Let's try this. Okay, that's perfect. Let's stay right there. And then we know where to go the next week and the next week, right? And really, that's the gap I think a lot of society has when they think movement becomes bad because they've developed pain with that movement. But what they really need is a skilled professional to say, let's keep doing that movement, but we're going to tweak these factors in it so you can stay in it, and then we'll build it back up and get you out of pain. So cool. Such a cool study, that Liftmore study, and really has highlighted what we can truly think about wear and tear in our bodies, osteoporosis, and appropriately loading over time. Tell me, as far as anatomically speaking, what really happens to these structures when we start to load them? What's actually happening inside the joint as we compress them? I'm thinking about calluses on our hands aren't the exact same, but I think very similar, right? We stress our hands. My daughter, I've told this on the podcast before, but she was doing the monkey bars in school, and she was like 6 at the time, and she was showing me her calluses on her hand, and she's like, "Look at my calluses; they're so thick and big." And she's like, "My friend was doing the monkey bars, and she was bleeding because she hadn't practiced like me all summer." And it was such a cool story because I'm like, she gets it, right? It's the practice, it's the graded exposure over time, and her hands adapted, right? So teach us a little bit anatomically speaking of what happens in our joints as we appropriately load them over time.
I absolutely love that story, by the way.
Nice.
It's fantastic. Yeah, so I'd say there's a lot going on when we load joints because it's going to depend upon the type of loading that we have. Because exercise is fantastic and it provides us with a wide range of different stressors, which is something that we can use to our advantage oftentimes. Because, for instance, if one type of stressor is irritable, there might be a different way that we can load it with different kinds of stress that we can manipulate and utilize. So, as you mentioned, one type is compressive. So that's where two structures are coming towards each other. And that can be, maybe you're performing a squat and you're feeling compression through your back, your knees when you're in the standing position. Or maybe you're kneeling down on the ground and you sit back and you feel that compressive force on your knees. In contrast, there's another type called like shear force, and that's where two surfaces are sliding across each other. And that can happen oftentimes within a joint when, let's say that you're sitting and doing a wall sit, so your back's against the wall, and then you're pushing forward, your knees experiencing a shear force there. Within those, we have a wide range of, more subtle versions, but essentially those are two of the main ones that we often discuss and are trying to manipulate to our favor. Within that, when we have something like a compressive force, when it's scaled accordingly, we can encourage the joint surfaces to actually improve in qualities. For instance, if we don't ever load those, that's where we might encourage bones to actually increase in thickness around and limit motion. Whereas if we have a lot of good quality compressive forces, we can maintain quality surfaces, for instance, the meniscus that we have inside of our knee, and it'll encourage this to continue to keep forming and be very durable. In contrast with something like a shear force, this can encourage, for instance, the ligaments inside and around your knee to become more strong and resilient. We've seen this in studies where they actually look at, for instance, youth populations and essentially identify how much jumping they do, and then see that jumping is associated with how thick their ligaments end up becoming, where the more jumping they tend to do, the more their ligaments adapt to accommodate to that task. In older populations, we can look at similar ideas where, for instance, if I'm working with an individual and they really struggle in shear loading with their knee, so like that going down the stairs example, that's a common type of force that they might have a difficult time with. If we go and then train that, number one, we can improve how well the joint surfaces slide across each other by managing the forces better with muscles. But then additionally, we can see changes in the tendons and the ligaments around the knee to be able to support that structure and not have the knee experience as much motion as it's going through those activities. And so we can really get a wide range of adaptations. That's one of the reasons why I really try to promote this idea of what's called movement variability, because essentially, as we take a more variable movement approach to activities, we encourage different stressors to our body, which then allows us to get exposed to them and then encourage adaptation across these wide ranges. That way, we don't just get locked in one very specific pattern. And the moment we deviate from it, we have no ability and then experience an injury or a setback.
What Sam's saying here is absolutely genius. The way you explain that is just like, it's so captivating, because a lot of physical therapists have a hard time teaching what you just taught, right? In explaining to people that you need variable movement, because you can't move in one pattern all the time and 98% of your day, and then all of a sudden you move out of the pattern, you develop pain with that. Say an example is you're only used to running unilaterally, right? You run all the time, and then your buddies call you up, and it's the turkey bowl. Everyone's going playing football Thursday on Thanksgiving, and you're going to go play for 4 hours. You're used to running marathons. You're used to running a lot in just one plane, but then you start doing cutting.
Great shape.
Yeah, and you're in great shape too, right? You're like, your cardio's there. You feel like you're back in high school health, right? You've worked really hard, and now you're going to go play football for 4 hours, right? And you're doing some cutting, right? You're not running just in one plane. You're moving, and your body is doing very, very different movements than they're used to. And tell us what happens in this scenario, Sam.
Yeah, unfortunately for a lot of those people, they can produce a lot of great forces, but they can't manage those rotational forces. And that's where we tend to see a busted up ACL, maybe a torn MCL. Maybe you step back and you blew at your Achilles.
But
And
they're
usually
totally in
they're,
shape, right? Like they've been
yeah.
working hard. Like why can't they go play football for hours? Help us close that gap to people so people really understand.
Yeah, I think one of the easiest ways for someone like that, I actually work with a lot of that type of population. And what we usually do is try to see if we can incorporate some similar but varied patterns within their training. So, for instance, we've got someone that's training for a marathon, they like to do a lot of running. Can we sneak in some plyometrics across different motions and directions at the start or at the end of their run on a regular basis? So, this might be you run 4 days a week, 2 days of the week. When you finish your run, we're going to do a series of different plyometrics that expose you to side motion, going from forward to backward and then backward to forward, not just cyclical action like you do with running. Can we incorporate some rotational plyometrics? And a lot of times we can start this off with a very low intensity, more extensive format where we do a lot more repetitions and then build that up as they're able to. But that regular exposure, which can honestly be very quick for a lot of my running population that I work with, it's like 2 to 5 minutes at the end of their run. It gets rid of this problem to where, again, you get invited to go play a game. You don't have to be as worried about it. And a lot of times you end up improving your performance. It carries over to running as well because, if I experienced this myself. Myself and a few coaches all decided to go do a marathon together. We trained for 4 months getting ready for it. Then when we went to go do the marathon, the course it was on was not that nice, and we experienced like a really sloped surface on the one part of the run. Then we ended up having this really hilly terrain where it was not steady hills where you start climbing and then you descend. It was just a very rolling format and quite aggressive. And across a lot of those areas where the surface was not as consistent, you would see a lot of people laying on the sides of the road because they ended up dealing with an injury. Whereas myself and the other coaches, we're not by any means, incredible runners, but we have a consistent variable training program to where we didn't deal with those types of injuries and, still able to finish. Maybe we could have ran faster if we spent more time running, but we're able to still finish and keep going.
And without injuries too, right? Like you prepared
Yeah.
yourself for the variability that you would experience. And I have this patient that comes to mind as you're talking about this. He has had this plantar fascia type pain, so this arch pain into his heel in his foot for 20 plus years, and he's coming to me and he's like, I don't know if I need surgery. Like, I don't want to have to manage this anymore. But every time I go to hiking I go out hunting, it flares up and it's like that for weeks. Every time I go to Disneyland with my kids and I'm walking a lot, it flares up for weeks. And I'm just kind of done managing it. And he's a real estate agent. And there's a lot of variability in his training, right? What message would you have for him on what he is doing to reinforce this 20 plus years of foot pain?
I first definitely acknowledge the challenges that come with that. I could see how that would be so frustrating to be able to navigate that where you seem like you're going the right direction and then you have the setback and then it just repeats over and over and over again. You've likely experienced, setbacks that then cause you to decrease in how much you can tolerate. Maybe these issues are coming on even faster than before. Maybe a few years ago, you would have been able to go for, a 5 mile hike, whereas now you're noticing even with 2 or 3 miles is starting to come on. And it's likely that we're seeing this, number one, through greater likelihood of increased sensitization. So the area gets irritated faster. But then additionally, it might be experiencing more load because the areas around it have lost a lot of abilities. Like maybe your calf is underperforming now, your thigh and hip muscles are also losing abilities. And so I can appreciate how that'd be so frustrating, and wanting it to go away is valid. Absolutely. I think that if we can dial in a way to get consistent volume in through a series of maybe activities that aren't like hiking or very challenging walking, maybe it's swimming, cycling, etc., to build up some general aerobic abilities, but then also find some exercise that we can do to target that region that don't set off your discomfort. Maybe we're doing some calf raise variations, maybe we're doing some foot strengthening movements, and then scale them as you report having positive recovery with it. And so maybe that at first, as boring as it may sound, is just a double leg calf raise on the flat ground, and we find that you report that well, then the next time, let's try a staggered stance. The next time, let's try a single leg. Let's try a deficit and slowly build our way up, because as we see your functional ability in those specific activities improve, we'll likely see that the plantar fascia actually increases in really positive ways, like improving its thickness, which can be beneficial when it's done through progressive exercise. And then it might also increase its tensile strength, so how much load it can bear. And then the supportive muscles around that region will likely increase in how much force and load they can tolerate before transferring as much demand onto the plantar fascia. And all together, that should allow us to then start to look at how we can get you back hiking and running and doing all the things that you want without needing to think about it.
Yeah, I love that answer because, yeah, surgery and the other alternatives is definitely not the answer. It's figuring out what are you consistently doing over the past 20 years that causes that to flare up and make those adaptations. And what are you not doing that's promoting it to happen again and again, because there's very specific things that he's lacking that is limiting his ability to stay consistent enough with movement, so where he does have the variability, it's going to flare up, right? But we get to that level where we're consistently doing certain movements and strengthening the foot and getting it used to those types of things, getting rid of his old compensations, and then building up enough resilience, and then it stays there. And then when he does go hunting, it doesn't bug him. So good insight there. Tell us, as we wrap up this conversation, tell us what are the things people can do consistently in their lives to not have these wear and tears, these arthritis things. Like, what are things people can consistently do to combat those so they don't even have those issues in the first place?
Some of my favorite things is to look at trying to find a good quality resistance training program that you can do. So for a lot of individuals, there's going to be a time aspect of what you can dedicate to it. But if you're more time restricted, I often try to get people to start off with looking at some sort of squat type activity, some type of hinge based activity, some type of press and pull. So for the squat, that could mean a goblet squat, it could mean a back squat, whatever fits well to you and you can do with reasonably little symptoms. If you find those activities challenging, it might be a split squat or a lunge or a step up. And then again, we can scale the range and the force demands accordingly. For the hinge, if you struggle with a lot of activities where you bend over, you could do something like a glute bridge or a hip thrust. Ideally, we start getting you standing and working on, deadlift variations and trying to find something that you can do as a good entry point. And then with pressing and pulling, this can be activities like bench press, push-ups, inverted rows, pull-ups, pull-downs, depending upon what you have for equipment. But ideally, starting off with a good rotation of those movements as a minimum, because that really challenges your entire body overall. There's some possibly missing links, but it gives you a good starting point. And then if we can get in 2 or 3 sessions of that a week with just even 2 to 3 sets of each movement to a meaningful degree, you can see some really positive improvements with that. If you're doing well with that, I like to add in some type of plyometric activity because it really does expose you to a different stress. What that looks like exactly is going to be, really dependent upon what you can handle. If you're someone that hasn't been highly active in, jumping or movement type activities for a long time, we could start off with some really chill exercises like a hand assisted pogo, where you're holding on to something like a doorway and just barely leaving the ground. And then over time, we scale that up and we start to ditch the hands, start to try to get a little bit more height, start to move side to side, forward and back, start to incorporate some knee bend, moving in different planes and directions. And that stuff we can really sneak in if it's in that extensive kind of format where it's for lower intensity and more volume. We can often use that as a warm up where, for instance, you're starting off and you're just moving around, bouncing, having fun, maybe getting on the ground and doing some crawling. That can be really great for your shoulders and ankles. And this just then allows you to get really warm and ready for your session. Then you can sneak in those few exercises that we talked about. And then some cardio, because at the end of the day, having a globally healthy individual transfers across the entire body. Improving your aerobic system will improve your knee health. It will improve your shoulder health. We've actually seen this, which is so fascinating, where they take individuals that are dealing with rotator cuff pain and they have them do a walking program and their pain improves. And so from this, we can really see that emerge to where challenging you, whether it's from, maybe you don't want to do it right after you finish your lifting, you just try to walk more throughout the whole day, or you go do a separate session where you're doing some dedicated work like swimming, biking, running, whatever activity you really find enjoyable, get after it and do it. And then try to, over time, build more time or cover more distance with that same time. Those kind of compound together.
Yeah.
So, yeah, I think that's a really great starting point.
Yeah. The wisdom in what you just said is, man, if every PT could repeat what you just said, and if every person in public did what you just said, right? Those are very simple things. You broke it down in such a simple way, and it's in a way that anyone can do it. Like, just start slow, 1% better every day. Just go and be active. Find something that you love. Make sure you have some variation. Like, these are tips that can literally change people's lives, and so important. My last question for you, Sam, is what advice would you have for someone that has been told that they have bone on bone and they X, Y, and Z? I'll let you fill in the blank there. There's many other statements that they can get on top of that, but they've just been told, I have bone on bone. What should I do? What's the next steps?
Step 1, take a deep breath and understand that there is a path forward for less symptoms, less pain, and more ability to live your life. Step 2 is try to find a quality practitioner who can help to guide you on that. That's ideally going to be someone who's close to you and able to support you, but in some cases that might not be the case. You might need to reach out to someone like myself online, or someone who's further away and you have to take that trip. Where possible, finding options to make the activities in your life less irritable on your knee or whatever area we're talking about is going to be ideal. Because if you end up having to just do less because you're in pain, that's not the situation that's going to lead us to a forward path of success. So how can we modify those issues to let you be as active as possible? And then finally, finding ways that we can reduce or improve your capacity so we reduce the demand on that painful area. So that might be doing dedicated resistance exercise, that might be doing different manual therapy. It's going to depend upon your specific situation, but in a lot of cases, you can get really good results from relatively simple things when performed well and done consistently. And so finding someone who can guide you in that process is really beneficial because, number one, people can often get stuck in a loop of not knowing what to do. But then two, having someone to just reinforce that consistency is huge for a lot of people.
I love it. Tell us the services that you provide, and then tell us how people can find you.
So I own and operate a facility here in Canada. If you end up in the region, come on down for a visit. I'd love to have guests. This is a really big travel destination, so I get lots of people who come in just to come say hi all the time. My facility is called Thrive Kelowna. And then if you're looking for online performance training, I have a company called Citizen Athletics where we offer what we call sustainable strength and a wide range of different programs available to support people on maintaining their functional longevity as well as possible. And then finally, if you're looking for online virtual rehab, I'm always here to help and support. You can contact me through my Instagram is honestly one of the easiest ways. You can see that I've got a link for direct access to that.
Awesome. Sam, it's been an absolute pleasure. I have so much gratitude for what you've done all these years. It's really shaped and modeled my mindset as a therapist and an actual patient too. And I've appreciated the challenge of the status quo, of challenging this idea that our bodies break down over time. I love the model and what you've taught, that our bodies are machines and they adapt. They're adaptable machines. And how we load them, how we do movement is very important. And movement is the best medicine. And it's such an incredible career that we're in to be able to teach people that. So thank you for all you've done and that you continue to do. You're making a significant impact. Appreciate you.
Well, thank you very much. It's wonderful to be on here. Appreciate it so much.
Yeah, thank you so much. Appreciate you. See ya.